In any case, I'm a radiation oncologist at the Charité, and I'm also an endorsed professor for electromagnetic fields in radiation oncology, and I'm very grateful by the support of Oncotherm. So the Charité was mentioned. What is that? Here you see some outline on my institution, and it's definitely the best hospital in Germany, and it's among the best hospitals worldwide, supposedly. In the next 25 minutes, I would like to go with you through the following points. I would like to share some data that I have on completed randomized trials to improve radiation therapy. This is my main goal, to improve the lives of patients with cancer, and I have some experience in that. I want to highlight the great potential that hyperthermia has. I want to share with you some recent preclinical results of modulated electrohyperthermia. Then I want to show you some early clinical trials that we are currently conducting at my center, and want to share with you some future developments. So let's get started. First of all, I have to say we made, and you know that, a lot of progress in cancer therapy. So for instance, radiation has so much improved technically. So we have radiosurgery, we have adaptive approaches and so on. Also the drug therapy for cancer has so much became better with immunotherapy and specified therapies, etc. But the truth is, cancer remains a major societal challenge. So it's only in the European Union, 1.3 million people die every year due to cancer. And we have to say this is mostly due to the unsuccessful treatment of locally advanced solid tumors, I would say. So everything which is common, prostate, breast, colorectal, cervical cancer, you name it. And the problem is that treatment-related toxicity can worsen actually the quality of life of the patients. And what we really need is a better treatment, a new technique that can increase the effectiveness of the therapies that we can use already without adding toxicity. This is what we require. So, regarding the completed randomized trials I conducted, I would like to start with those on locally advanced head and neck cancer. So already a long time ago, colleagues of mine and I, we thought, let's add chemotherapy, let's add cisplatinum to radiation, let's do radiochemotherapy. And this here you see the two Kaplan-Meier curves with cancer-specific survival on long-term outcome. Those two trials with more than 500 patients in total. Left side, Swiss SAKK 1094 trial. Right side, the German ARO 9506 trial. And what you can clearly see that the cancer-specific rate is significantly better when you use additional chemotherapy. So this has now become the standard of care. But cisplatinum does not come without any burden or cost. It can cause significant side effects. It's a toxic therapy, radiochemotherapy, especially to frail patients or older patients. Sometimes you cannot even use it. So let's go further. Then I thought, okay, let's increase the radiation dose. So we performed this randomized trial, the Swiss SAKK 0910 trial, 350 patients again, and we increased the dose for post-prostatectomy salvage radiation therapy. Easy trial design, salvage radiation to the prostate bed alone, 64 gray compared to 70 gray. And the primary endpoint was freedom from biochemical progression, so PSA follow-up based. So here you see the final results that we published in European Urology some time ago, and surprisingly, there was no benefit from the high dose. But what we did see is that when you use high dose, then you actually increase significantly the late rectal toxicity. So what will be the outcome? And this will be incorporated in European guidelines. Let's use the lower dose because it's more sufficient and it prevents patients from getting toxicity. So if you do trials like this nowadays, it's not enough, I believe. We have to gain further insights. We have to approach something in the direction of personalized cancer therapy. So we did analyze some patient data from prostatectomy tissue in a translational approach. And we analyzed the gene signature called PORTOS. This is associated with radiosensitivity, and this is a good thing to have, because you see if you have a high PORTOS score, then you significantly benefit from the dose intensification. So what we're going to do in the future, measure the PORTOS score as a predictor of dose intensification. And why I'm telling you this? Because I believe future trials incorporating hyperthermia, they also need something like this, a translational approach. So let's go to the most important thing, which is hyperthermia here. So is there any potential? Of course. Here you have two graphs. Let me guide you through the graphs. They show that there's a synergistic effect of heat with radiation and chemotherapy. So cells were treated in vitro by radiation that you see on the left side or by chemotherapy that you see on the right side with different temperatures using water bath, and the surviving fraction of the cells is plotted here. That means when the curves fall off more sharply, then there's more cell kill. So if you look on the left side, we can take home from that if you do hyperthermia to 42 degrees for 60 minutes, this is kind of standard treatment time for hyperthermia, you double the cell kill of radiation. And even at lower temperatures, let's say around about 40.5 degrees or so, there's still an expected radiation enhancement of 10% preclinically. Remember that number. On the right side, you see synergism with chemotherapy starts even at lower temperatures. So 39 degrees might be sufficient. So when we want to treat and use hyperthermia, there are a bunch of different technological approaches, but when we want to treat like locally advanced tumors, which we have to, because this is the clinical problem, then we are bound to these local regional heating techniques that were mentioned before, and I'm going to concentrate on a capacitive local regional hyperthermia approach, which is a very good approach. And Oncotherm is the main vendor, as you know, for this kind of techniques, called also modulated electrohyperthermia. So there's not only preclinical data, so I have a view on that with a high potential for hyperthermia based predominantly on clinical data, and I want to show this now to you. So this is a nice meta-analysis of a colleague of mine who looked, to what extent is actually hyperthermia radiosensitizing. And he included 38 clinical trials, almost 3,500 patients from very various cancer entities that you see here, like including breast, cervix, head and neck, rectum, bladder, and so forth. And the bottom line was that the complete response rate of radiation was 15% increased. And this is very important, and this exceeds the preclinical expectations, actually. 15% is a lot. This is more than sometimes chemotherapy can give you. And if one asks, okay, but where is randomized data that addition of hyperthermia would increase really the hardest endpoint that we have, which is overall survival. Then look, there are multiple positive randomized trials on different cancer entities with a positive outcome for overall survival when you use hyperthermia plus radiation as compared to radiotherapy alone, including rectal cancer, including head and neck, glioblastoma, and cervical cancer. And what is very important here is that all these clinical reports have one thing in common, and this is they do not report on high-grade toxicity. So it appears here we have something which is really boosting the effectiveness of radiation without any clinically significant toxicity. So, and this is not all. We have data from a clinical trial. I was also involved in a long-term follow-up, a large European trial, EORTC trial, comparing neoadjuvant chemotherapy for high-risk sarcomas with neoadjuvant chemotherapy plus hyperthermia. And you see the Kaplan-Meier plot for overall survival on the right side, and it's just that the mean survival is substantially more than multiple years prolonged when you use hyperthermia. And this data leads hyperthermia to be part of the European sarcoma guidelines, and this is very important. So, talking about a European trial, I would like to mention that there is a scientific organization called the European Society of Hyperthermic Oncology, ESHO. I'm the vice president. I'm very honored here for this distinguished audience to mention this. If you are interested, which I hope, in hyperthermia, you may consider to check out the annual meeting. This is in November in Spain. Would be very happy to see you again there. So let's go to some preclinical data, which I think is very important, specialized here or focused on the modulated electrohyperthermia approach. So what is that? Professor Saas told it already. So what do we have? We have a carrier frequency in the megahertz range, and this can induce heating to the tumors. But we have this amplitude modulation at a low frequency, and I will show you later that I think it's very important to have that. So it's in the hertz to kilohertz range, and it comes together with the carrier wave. And I believe that the low frequency amplitude modulation can exert some extra effects, probably at the cell membrane. So already 15 years ago, Andox from Hungary showed in a xenographed mouse model that the MEHT approach is actually more successful than temperature increase alone. This is very interesting. You see, he was treating the mice with 42 degrees regular heating. This is the dark gray bar. And then he was using the MEHT approach, heating up also to 42 degrees, but using this amplitude modulated electromagnetic fields. And you see the red bar is really outperforming the cell kill in the mice. It's much more effective. And then he made a trick. He said, okay, let's go down to a lower temperature, like 38 degrees, this is the bar on the right side, and apply MEHT, and it was still more effective than the regular treatment at 42 degrees. What does that tell us? We heard it before. Probably there are other anti-cancer effects beyond the direct temperature effects that are caused by that treatment. And this is very important because for hyperthermia, sometimes you cannot reach the temperature deep within the body. Can you heat up a pancreas to 42 degrees? This is, can be problematic because of the perfusion of the patient, etc. So we really want to have a treatment that can induce mild hyperthermia and exerts extra anti-cancer effects. So after more than a decade of preclinical research based on Hungarian mostly and Asian groups, there's this very nice review by Krenach et al. And it really highlights very nicely, for your interest maybe, the mode of action of MEHT. And it induces ion fluxes and ion disequilibrium. This is very important. We have, for instance, voltage-gated ion channels at the cell membrane, and it's easy to understand that those are probably affected by the electromagnetic fields. MEHT induces DNA double-strand breaks. It causes, we heard that, immunogenic cell death, but it also increases the chemotherapy drug uptake in the tumor, and it does really radiosensitize by reduction of hypoxia. So all that together is actually what we want to have when we treat cancer patients. Okay, and then we started to work at the Charité at my center, and we didn't want to repeat all the evidence of the last decade again, but you know, we have somehow to convince ourselves, and more importantly, maybe to convince our fellow esteemed colleagues, like from medical oncology or so at my institution, is not very easy. So we started off with some preclinical own data, which I want just briefly to show you. So in vitro on the left side, using the Oncotherm preclinical device, we were treating a colorectal cell line, and we saw just more cell kill as compared to the heating with a water bath. And that was convincing us a lot because it was just fitting to the story that I just showed you. And we didn't stop there. We went to a mouse model, you see on the right side, and then we were actually looking on, okay, what about the amplitude modulation? Is this really required? Can we also treat just with radiofrequency at the carrier frequency? But this was not the case. Look, the light gray bar was the effectiveness of the unmodulated fields, so the tumor growth. But the tumor growth was significantly better stopped when we used the MEHT approach with is the yellow bar. So this was just the winner. And this was convincing ourselves, and this was also convincing our colleagues in order to do trials. So then we browsed through all the literature, and we had to make up our minds. So why is that? Why do we have such effective treatment without any toxicity? And we heard about this in the talk before a lot, and this is all true. And I believe the cell mechanics are important, and also the ion channel expression of cells. And I tell you why I believe this Oncotherm technology can be actually the basis for cancer cell-specific therapy. And the reason for that is, you know, cancer cells in the cell mechanics, they differ significantly from healthy cells. Healthy cells are relatively rigid and well organized, but in comparison, cancer cells, they like to migrate, they want to be invasive, metastasize, they are more flexible. And we measured that with a scanning force microscopy you see in the upper right. We were measuring fibroblast and colorectal cancer cells. And colorectal cancer cells are much less stiff or more flexible. So is it maybe that we induce some resonance phenomenons at the cells with a low frequency, which is in the range of the resonance frequency you can calculate for the tumor cells? So maybe, can that be a reason why we do not harm the healthy cells? So maybe, we have to do some further research, but it's very interesting, I believe. And also, there's a significant difference, you can check it up in the literature, between the ion channel expression in healthy cells and cancer cells. This is named a channeloma, leading up to actually a very significant membrane potential of healthy cells and cancer cells. And now knowing that we use electromagnetic fields and probably ion channels in the cell membrane are a target, this can be really the basis of a cancer-specific therapy, I believe. So, we showed the preclinical data to medical oncology, to GI oncology, to neurosurgery, and so they were kind of impressed by that, and they allowed us to do some early clinical trials because the patients at our centers, they are very esteemed, and you cannot do just a trial without the confirmation of these fellow colleagues. But we start two trials which I would like to share with you. One is called the LIFE-RF trial. It's a phase 2 trial, and it combines MEHT with chemotherapy in colorectal patients, cancer patients with large liver metastasis. They have a problem because we are talking here about third-line chemotherapy, a resistant situation, and if the liver is not working, then the patient's going to die. So we need some extra help here. For the background, there's a medication called Lonsurf, and some time ago it was shown that it would improve overall survival over placebo. But the objective response rate of that drug is below 2% only, which is nothing. And just recently it turned out that the combination of Lonsurf and bevacizumab is actually superior to Lonsurf alone. But still, the objective response rate is only 6%, so there's a lot of room for improvement. So this is actually the backbone of our trial. And we will add MEHT to that 2 times a week. And we hope that we can have 3 from 12 patients responding. And we have some interesting secondary endpoints. We are taking blood and measure the immune profile of that patients. And we have now 2 patients included, and it's too early to show some results to you. But if you're interested, it's not only approved by ethical committee, of course, but it's registered in clinicaltrials.gov, so you may check it out there. And I hope at a later occasion I can show some clinical data. So let's move forward. We have another trial. We talked about glioblastoma before. It's really a killer disease. It's terrible, so we need to do something there. And here you see the STUP scheme, which is the standard of care still. It's a radiochemotherapy with 6-degree concomitant temozolomide chemo and adjuvant chemo, leading up to a progression-free survival at 6 months of around about 54%. So this is the backbone. And we believe that additional, let's say, local regional treatment by MEHT could improve these rates. So this is our design. During the 6 weeks of radiotherapy, we would do 3 sessions MEHT per week, and then during the adjuvant temozolomide chemo, 2 sessions per week chemo. We are ambitious. We want to lift up the PFS6 rate to 80%. We have to be ambitious. We have good reasons to be ambitious. Yeah, and this trial we're going to include 26 available patients, and it's running quite good. We have 5 or 6 patients on that trial. Again, it's too early to show some clinical data. Also registered in clinicaltrials.gov, so please check it out if you're interested. So, well, I believe we have to further conduct preclinical research just in order to better explore the mode of action even better, because then we can have maybe novel drug combinations and so forth. RNA sequencing will play a major role in that. I believe we need further preparatory trials. We have many ideas. One is to target inoperable hepatocellular cancer, maybe ovarian cancer as well. Yes, and then, of course, we need multicentric international confirming phase 3 trials. And with that, I'm going to close, but saying that with your help, and maybe your help, together we can improve the lives of patients with cancer. Thank you very much for your kind attention. And I would be happy if there are any questions then, to answer.
surgeon. So is this Oncotherm already standard of care in Charity?
Thank you for the question, first of all. It's a big word. So in terms of we get reimbursement or that it's standard treatment outside of clinical trials, this is not the case. But I'm confident that, I mean, we will follow up on the road to have early trials at our institution with good results, larger trials, and then, you know, after phase 3 data, which we have for cervical cancer, but it's then sometimes not the case that in Germany the insurance company is going to pay, then we hopefully make it to a reimbursed therapy. All right. So then thank you very much again for your attention. Or there is a question. Sorry.
Dr. Ed Zarate, Life One Corporation. I'm an internist. You mentioned the different transmembrane potentials, negative 80 for normal cells and negative 30 for the transmembrane potential of malignant cells. In the application of MEHT, doctor, is there an LD50 is there a study conducted whereby a certain dose would constitute damage to the normal cells, surrounding normal cells around the malignancy, which would constitute what we call as a lethal dose 50, as if we make a comparison akin to pharmaceutical preparations that would always indicate what the LD50 of each drug would be. Is there any such study having been conducted?
Thank you for the question. What I can tell you is that there's clinical dose escalation trials in GBM patients, and they went up to 5 sessions per week, assuming, and this was the conclusion, that 5 sessions per week is actually tolerated by the patients, by the real patients, I mean. So 5 times a week, 60 minutes is tolerable. However, due to practical reasons with these patients, then you can ask yourself, is it not too much, 5 times a week? We use 3 times in our trial, but 5 times a week in such a prospective dose-finding trial was deemed to be tolerable. So I cannot mention you specific LD50, but I can tell you in the clinics, it's working.
Thank you, sir. I have a second question, please. What kind of malignancy is most responsible to modulated electrohyperthermia? Or has there been any comparative analysis or a study of the clinical efficacy between carcinoma, sarcoma, or even malignant teratoma?
Well, all the entities that you just mentioned, there's good evidence for hyperthermia. I mentioned the sarcoma. There's another thing on children, teratoma. We will hear later on from my colleague about cervical cancer. You saw that before. So I cannot tell you, a range of cells, but my impression is that most common solid cancers are responding very well, and also the sarcomas are responding very well, and also malign child tumors going into this teratoma section in combination with chemotherapy, they respond very well to hyperthermia.
So at this stage, sir, we cannot make any claim that MEHT is, let's say, more effective for carcinomas, or it is more effective for sarcomas, or the other types of malignancy. Instead, we can just say, in general, that MEHT is effective equally for all types of malignancy.
I would say so.
Thank you.
Carrie?
Thank you. Your talk was lovely, as always. My question is not for you, but I would like to add just to your points, if you don't mind.
Sure, go ahead.
Thank you. So because the MEHT works on the difference in the biophysical properties between malignant and healthy tissue, so the difference in conductivity, resistance, permittivity, the more aggressive the tumor, the more metabolically active they are. And that means that the difference between the tumor and the healthy tissue is higher. So in theory, the more aggressive tumors and the advanced tumors are more responsive than your very slow-growing tumors, such as the slow-growing prostate tumors. But the other thing that's really important is that when we're looking at how the tumors are sensitized, we want to look at the tumors that are radioresistant and hypoxic, which means any tumor larger than 2 centimeters or in a previously irradiated field would be more responsive than your smaller tumors when you combine MEHT with radiation. And then the other point, just in terms of the tumor types, we do know for sure that squamous cell carcinomas, especially those that are HPV induced, are more responsive and should definitely be treated with MEHT. And the reason being they rely on E protein 6 during their, for their metabolic processes, and these pathways are inhibited by heated conditions. And then, just regards to the dose, the selectivity of the technique does not allow for damage to the immediately surrounding tissues. The only dose limiting consideration one needs to take into account is a thick adipose layer. So if there's a very thick, and I'm talking about a BMI in excess of 30, so very thick adipose layers, those patients typically need to have a lower power output, which means we treat them for longer, but we can still achieve the same dose.
All right. Then thank you very much again for your kind attention.
Thank you for that beautiful deliberation. In any case, we will still have Q&As in a later portion, but we can also continue extending that question to the floor. Yes, sir.
Am I allowed, sir?
Yes, sir.
Thank you, Dr.
By all
Lazaro.
means.
Yes, thank you, Dr. Lazaro. Thank you, Professor GHADJAR, for that wonderful presentation, particularly on the cellular level. I'm Dr. Yolo, I'm a pathologist. Now, my question is, I see the articles, the articles that you projected earlier. They do have impressive endpoint, and particularly you mentioned the ambitious PFS. Now, among these studies, is there any pathologic evidence of response? Meaning to say, was there any biopsy post-hyperthermia therapy ever done as the basis for pathologic response? What we're seeing here are just progressive-free survival. But is there pathologic response? Meaning to say, was there any biopsies done in these studies?
I think to some extent there was, especially when it was possible to be combined with clinical routine. For instance, I was showing you the rectal cancer trial, and this was a neoadjuvant trial.
Mm-hmm.
So it was possible in the resection specimen to compare with pre-treatment biopsies. And in this case, there were also histological analysis, I believe, confirming then this immunogenic cell death and necrosis done. So yes, also, for instance, in the sarcoma trial, in the large sarcoma trial,
Right.
Also, this was a neoadjuvant therapy, so pre-treatment biopsies and resection specimens then after the neoadjuvant therapy were available, at least for a large subset of that trial, and it was published in the European Journal of Cancer that there was actually, interestingly, immune infiltration to a higher rate in the hyperthermia arm, so actually suggesting involvement of the immune system after that neoadjuvant combined chemo plus heat compared to chemo alone. And for instance, in the hepatocellular trial that we are planning, then we will also look into tissues, biopsy. Then there is a rebiopsy standard after, I think, 3 or 6 months, and then we will definitely look into that. So there's some data on that, so some proof of the effectiveness also in terms of pathological examination.
Thank you very much.
You're welcome.
That was Professor Dr. Pirus GHADJAR, MD, PhD. Thank you for such a beautiful deliberation.